Have you ever been confused about certification, which certification exam you should take? There are so many out there. Every specialty has a certification exam, but sometimes you wonder, are these nationally accredited exams? If I move from Massachusetts to Nevada, will that certification exam serve me well? There are 3 very large sanctioned national examination organizations that you know if you take their examination, you will be golden. That's the PCCN, AACN, ANCC. Those are nationally accredited, sanctioned organizations that give examinations. Hi, I'm Cammy Christie. Please join me with MedEd. Get your certification review in preparation for a sanctioned national certification. Welcome to MedEd's production of the PCCN Exam Review. My name is Cammy Christie and I'm your presenter for today, or this module. And this module is Pulmonary Part 1. Because pulmonary is, again, a larger part, about 17 or 18% of your exam, we're going to do, it's quite a long review. We're going to do it in 2 parts. Part 1 is about an hour, Part 2 is about an hour. Let's start with Part 1, which is the essentials of pulmonary care, a little bit of physiology, a little bit of pathophysiology, and then Part 2 is all of the pathophysiology things that you may see on your exam. So this is a great picture. This is where I work as an acute care nurse practitioner, and this is a lung transplant happening. And the surgeon is Dr. Staples, and that is a brand new healthy lung sitting on top of that man's side chest. The lung doesn't look very good, but it doesn't have any air and it doesn't have any blood flow, so they're just preparing it to go in. Once it goes in and the pulmonary vessels are all sewn in, and so it's full of blood, and the bronchioles are all full, and the anesthesiologist starts to bag that lung up, it turns nice and pink and clear and healthy. So the lung, if you remember, the purpose of the heart was to drive blood to the cell. Remember, the heart, it has some endocrine properties, but it's really a pump. The purpose of the lung is to oxygenate and ventilate that cell, that hemoglobin, so that now you have 2 things that work together, something that oxygenates and ventilates the hemoglobin, and one that pumps that hemoglobin to every cell in the body. So really, you can't separate cardiopulmonary function. They go together. If somebody has a really bad heart, they're end-stage heart failure, their lungs are full of fluid, and they have pulmonary hypertension. If somebody is a big smoker, they've had asthma for a long time, emphysema, COPD, and they have very high pulmonary pressures, their right heart takes a hit with that, and many people develop cor pulmonale or right-sided heart failure. So you can't separate the 2. The first thing we're going to talk about is how the lungs work to oxygenate and ventilate that hemoglobin. Well, you have to have 3 things that are working. Number 1 is the brain. The brain is going to tell you, because it has sensors all over the body that picks up oxygen and CO2 detectors, tells you how fast to breathe and how deep to breathe. Righty? So the brain has to be working. The brain stem has to be working. The brain then tells the bellows, and the bellows is the sternum, the spine, the rib cage, all the intercostal muscles, the accessory muscles of ventilation, and the diaphragm, how fast to move your chest. The amazing thing is that your chest wall, or the thorax, always works symmetrically. So when your brain says take a deep breath, or take a breath in, the diaphragm moves down and the chest wall opens, but it opens very symmetrically. That actually takes a lot of energy, because your lung, which is wet, it has blood in it and it has some secretions in it, it wants to stick together like a sponge. So for you to open up that lung cavity, that cavity, and open up the lung, it's going to take a lot of work. So that's energy. When you do that, when you open everything up like that, now you have created a negative intrathoracic pressure. So it's a negative intrapleural and a negative intrathorax pressure. And out here, this atmospheric pressure is always positive. So as you make that negative pressure, air from the outside rushes in and fills that space. When the person exhales, when you exhale, That's relatively passive unless you have disease. In a normal person, it doesn't take any energy to exhale. The diaphragm comes up, the lung has what we call elastic recoil. It goes back down and squeezes the air out. So the brain and the bellows have to work together, and the bellows has to be symmetrical. If somebody has 2 or 3 fractured ribs just on one side, that can cause a patient to have what we call paradoxical movement or flail chest. The chest now is not working symmetrically. The area underneath those fractured ribs is not going to expand as well as the other side. And now you're going to have lung contusion, have atelectasis, maybe blood in the lung, and that's an area that's not going to oxygenate or ventilate. So everything has to work together. The last part of this system, so that it works well and you oxygenate, ventilate your blood, is you've got to get it all the way, you've got to get that air all the way down to the alveolar spaces. And this is just a picture of deep inside an alveolar sac. You can see that there's a little disease. You see those little holes about 3 o'clock there. That's not normal. But the alveolar sac is like a honeycomb. Each alveoli, they share a septum with the one next to it. So it's very much in communication with one another. So the last part of the system is you get air into the lung, and the air gets into the alveolus, the top of your slide there. That's alveolar ventilation. All right, I got air in there. Now that oxygen has to diffuse from the alveolus through those little dotted lines. That's the surfactant. That's what keeps the alveolus open. Remember, that's what decreases surface tension and keeps the alveolus open. So it has to diffuse through that, diffuse through the alveolar wall, and in normal people, that's only one cell. It's just one cell thick. In people with disease, that might get multicellular, and the alveolus gets thick and stiff. If you remember, if you've heard in some of the other presentations, things that get thick and stiff in your body are not good. Thick and stiff leads to higher pressures. And people develop pulmonary hypertension. Then that oxygen has to diffuse through the interstitial space, which is filled with just interstitial fluid, so it's very easy for oxygen to diffuse through there. In disease states like ARDS, interstitial edema, and especially ARDS, there are white cells that get in there. In pulmonary fibrosis, there's fibrin that gets in there, and that decreases the ability of that oxygen to diffuse through. Then it has to go through the capillary bed. Again, it should just be one cell, one little tiny, less than 1 micron, through there, and then into the blood. And if the pH is normal, and the glucose is normal, and the hemoglobin is normal, it attaches to that hemoglobin. That capillary bed in disease is also going to get thicker and stiffer, and that's from disease. So in reality, the time it takes from that oxygen to get to the alveolus to hook onto that hemoglobin is less than 0.2 milliseconds. It happens very fast in normal conditions. In disease, though, you can see all the different places on that slide where oxygen can have a problem getting through, and that would create an oxygen deficit for the patient. CO2 does exactly the same thing in the opposite direction, but CO2 is 20 times more easily diffusible than oxygen, and it doesn't take any energy. It takes a lot of energy for that oxygen to diffuse through, none for CO2. So as long as the patient is taking normal tidal volumes and normal respiratory rate, air comes in and washes that CO2 out with exhalation. If patients have decreased tidal volume, decreased rates, CO2 builds up in there, and then CO2 does not diffuse, because CO2 diffusion is all secondary to a gradient. You know, there's more CO2 in your blood than there is in the alveolus, so it just pops out. If the alveolus starts getting pretty heavy with CO2, then there's no diffusion. All right, so that's just alveolar ventilation. That's just all normal, but you can see where disease can occur. This slide again shows you we're just talking about normal physiology, but one of the basic concepts that we talk about always with pulmonary care and taking care of anybody with lung problems is VQ matching. V with a dot on it is ventilation. Q with a dot on it is perfusion. So for every alveolus that's open, there should be ventilation. You should have air in there, alveolar ventilation. And for every alveolus, there should be a capillary bed right next to it so you can have ventilation and perfusion so you can oxygenate and ventilate. In the upright lung, if you look at figure A up there, in the upright lung, normal people like to be in the upright position. Oh, Cammy, I sleep 10 hours a night. Yeah, you might sleep 10 hours a night, but you move around in your sleep. But the rest of the day, you're usually in an upright position. In that position, you can see that the apices of the lung, the top of the lung, is the best ventilated, and the base of the lung is the best perfused. That's because blood is heavier than air, and that usually always happens. That doesn't mean that the apices don't have blood flow. Yes, it does, but it's a lesser pressure than the base. So that's normal. But if I said, your house has just caught on fire, run for your life, and you have to stand up and run for your life, you are frightened that fire is going to get you, the first thing you'll do when you stand up is take a big deep breath and run. Because when you're just at rest, if you're just sitting in front of the computer, your tidal volumes aren't very high and you're not breathing very fast. You're oxygenating just fine, but some of your alveoli are going to be closed. And your body's very smart. Where you don't have any air, no gas, you're not going to have any blood flow. Why have blood there if there's no air to exchange? So your body shunts that blood over to where an alveolus is open. That's normal shunting, normal physiologic shunting in your body. But when you stand up and take that big deep breath and your heart rate goes up, what happens is all your alveoli that are closed are going to open. Blood flow automatically will come there because now you have air in there, and you're going to look like the bottom slide C. Perfect VQ matching. Perfect. So when you took that deep breath, that's called, and you opened up all those other airways or those alveoli, that's called alveolar recruitment. You recruited your lung all the way open. So what we want to do in the hospital setting, you have a patient laying in bed, look at B. When you lay in bed, you create VQ mismatch. Now you have blood at the posterior, air at the anterior, and now you can have some people that get hypoxic. So what we want to do always with people, post-op people laying in bed, people who are not moving very well, they're not getting up and ambulating, you're going to do some recruitment maneuvers. In the non-intubated patient, what do you do to recruit the lung open? What's the strategy, the nursing strategy you use? You use the incentive spirometer, correct. Incentive spirometer. Have that patient take slow, deep breaths, and they'll take that slow, deep inhalation. That alveoli is going to open, blood flow will come, and you improve VQ matching. So this whole concept is alveolar recruitment and VQ matching. And you have to have VQ matching. The number one reason your patient is hypoxemic is because of VQ mismatch. So I want you to remember this is a very important concept. We're talking here about pulmonary care. In the ventilated patient, on a respirator, the way we recruit the lung open is with PEEP, capital P-E-E-P, PEEP, positive end expiratory pressure. So the ventilator gives the volume and the pressure and then keeps that pressure in the lung even when the patient exhalates. Right? So these are very important concepts for you to understand about oxygenation. These next few slides, I'm going to talk again about VQ matching. But this is what I want you to be thinking. I want you to be thinking you're working nights, and you are the charge nurse for nights. And you have a couple of brand new nurses, and you have a couple of, your regular nurses. But it's a busy night, and you have a brand new nurse that comes up to you at 2 o'clock in the morning. Now, you've been working since 7. This is 2 o'clock in the morning. And the brand new nurse looks at you with those sparkly eyes and says, "Can you come look at my patient?" Now, that should strike terror in your heart. But you don't let it show on your face, and you go, "Sure, what's happening?" And the young nurse says to you, "Well, when I came on last night at 7 o'clock, I checked my patient at 8. They were on 2 liters nasal cannula, and they were satting like 98%. But then they kept dropping their sats and dropping their sats, and now I have the patient on a 60% aerosol face mask, and the patient, I can't get the sats above 90%. Yikes. So here's a young nurse that's come to you and says, over the last few hours, I've added more and more and more oxygen from 28%, 2 liters, to 60%, and my sats are worse than they were when I started. Well, that should, that's a red flag. Anytime you have to add oxygen, there's a problem. So the problem is hypoxemia. And you know in your head that the most common cause of hypoxemia in the hospital setting is VQ mismatch. But VQ mismatch, there can be a lot of different reasons for VQ mismatch. So if you look at this slide, the next slide, this is normal VQ matching. Now when you look at this side, and in your handout, on the left-hand side of that picture is the right ventricle. The right ventricle, unoxygenated blood, pumping blood to the pulmonary artery, the only artery in the body that has venous blood. And it's pumping it to the alveolus. CO2 is dropped off, oxygen is diffused through, and then as soon as oxygen hits that vessel, it now becomes the pulmonary vein, the only vein in the body that has oxygenated blood, and that right ventricle is pumping all the way to get that blood into the left ventricle. Normal oxygenation and perfusion. So this is all normal. This is normal. This is what you should have. Patients should have a normal sat. What can cause VQ mismatch is what I'm going to show you next. There's 2 major types of VQ mismatch. This is high ventilation, low perfusion. And you can see the alveolus is open. Patient's taking a good tidal volume. They have good respiratory drive. But look at the blood vessel. Look at the one before it and this one. This is really tiny, pitiful blood flow. So in this patient, they are hypoxemic, secondary to low blood flow through the lung. So here's what I want you to do. You're walking down to that room and you're thinking, I know that hypoxemia is caused by VQ mismatch. One type of VQ mismatch is poor blood flow. So what are some of the things that could cause that? Well, poor blood flow from the right ventricle to the left could be that the patient has poor venous return. They're bleeding. They're obviously bleeding. They have very low blood flow. So you walk into the room, and I guarantee you, if somebody's bleeding, you'll notice it. If they're bleeding out their butt, and you look at the NG tube, and the canister is full of blood, their belly's toted out, there's blood coming down their chest tube, you're going to notice it. Alrighty? Another reason for this kind of decrease in blood flow would be that the right ventricle is not working, like acute right ventricular infarction. Now that would be a little hard to see when you just walk in the room, so you would want to get a 12-lead EKG or a 15-lead EKG to look at that right ventricle. But the most common cause for this type of VQ mismatch is a pulmonary embolus. 90% of all pulmonary embolus in the hospital setting come from lower extremity DVT. So the patient developed a DVT, and a piece of that clot broke off, traveled up the vena cava into the right atrium, right ventricle, out the right ventricle, into the pulmonary artery, and caused an occlusion, and now you have no blood flow. So the 3 things you think about for this kind of VQ mismatch: are they bleeding? Decreased venous return, they're very dehydrated. Do they have right ventricular infarct? Or most commonly, did that patient have a pulmonary embolus? Right? So this is high ventilation, low perfusion. The next type of VQ mismatch, so that's what you're thinking on one side. Now the other algorithm is, well, maybe they have low ventilation, high perfusion. So that means that perfusion is good. Their right heart's working great. You have plenty of volume, plenty of hemoglobin. But now look at that alveolus. It's collapsed. What are some things that could give you that? Well, there's a lot of different things. One, you walk in the room and the patient looks like this. They're way sedated, mental status change, they're not breathing very frequently, and their tidal volumes are very low. So you ask the nurse, when was the last time you medicated this patient? She says, well, the patient's been having lots of pain, complaining of 10/10 pain, so I've been giving them 0.4 of Dilaudid IV every half hour. Yikes, yikes. Now the patient is very narked, yeah, and they're not taking a deep breath. So we're going to need to wake that patient up so they can take a deep breath and open up their alveoli, right? But maybe you walk in and the patient looks like this. They're all hunched over and they're breathing. They're hyperventilating, but taking very, very low tidal volumes. Again, because now the patient's in pain. They're in terrible pain. When was the last time you gave the patient pain medicine? Well, the patient didn't want any pain medication. He doesn't like the way it makes him feel. The patient's having hypoxemia because of hyperventilation because of pain. Well, we can fix all of that, but that's what will happen. What if the patient had a big mucus plug and was plugging off part of their lung? They had an occlusion to their airway. Or what if they had asthma? Now, occlusions to airway and asthma, usually the patient will have a wheeze. You walk in the room and you hear wheezing, the patient's obviously having a big asthma attack. You say to the nurse, well, did you try an albuterol treatment? Well, no, I didn't give albuterol. The respiratory therapist didn't think you needed albuterol. Well, they need it now because they're wheezing and they're all clamped down, they're tight, they have bronchospasm, they're not moving any air. A big mucus plug, that's a little bit different. You got to try to get the patient to cough, move the mucus plug. If it's a really big one, when the doctors come in and get a chest x-ray and you see, collapse of part of the lung, they may need an awake bronchoscopy, or we may need to do something a little bit more aggressive. But the best thing you can do is get the patient to deep breathe, cough, use the incentive spirometer, sit up and cough. Another thing is if that alveolus was full of pulmonary edema, full of fluid. Now again, I think you would notice if the patient was in pulmonary edema, they have pink frothy sputum in their aerosol face mask, they're breathing 36 times a minute, and they're hypoxic and look in trouble. Now what do you do for pulmonary edema? Stop giving volume, righty? Give Lasix or some type of diuretic and hope that the kidneys are working so that the diuretic will work. But stop giving volume and diurese the patient. The most common reason for somebody to have low ventilation, high perfusion mismatch is that alveolus, the patient has had aspiration. They have aspiration pneumonia. So they've aspirated tube feeds, food, saliva, and now they've got consolidation and their alveoli are down. Now, that's a different story. Aspiration pneumonia is very bad. Now we have to treat them for pneumonia. But in this situation, low ventilation, high perfusion, you still have to get the patient in the upright position, sitting upright, arms up. You have to get them to cough, deep breathe, use the incentive spirometer. You may have to diurese. Righty? So you can see you have an algorithm in your head when you walk down there. So for the test, and they say that your patient's hypoxemic, hypoxemia is most generally caused by VQ mismatch. Is it there's no blood coming or the alveolus is collapsed? What do I need to do next? All right, so it gives you a very nice algorithm of how to take care of these patients. So your pulmonary assessment, this patient is in trouble, so you vomited. You actually went in and got the patient in a good position, righty? You made them NPO. You did their vital signs. And in that vital sign, you really looked at their respiratory rate and rhythm. Remember, nobody breathes 20 times a minute at rest. Normal adult respiratory rate is 8 to 12. Right? So if they're breathing 30 times a minute, you know something's wrong. Look at their rate and look at their rhythm. You can do O2 saturations, oxygen. Remember, vomit, O is oxygen. Tracheal deviation, we're still doing our assessment. In a non-intubated, non-trached patient with the head in neutral position, this is not neutral position. Neutral position, the trachea, here's a good picture, the trachea should be midline. The trachea deviates away from pressure. So if the patient has a pneumothorax or a tension pneumo, the trachea is going to move away from that. So the trachea moves away from air and it moves toward fluid and consolidation. So if your patient had a huge right pleural effusion, right, from that liver failure, if they have a lot of atelectasis and pneumonia on the right, the trachea is going to move that way. So it moves away from air toward consolidation and fluid, right? And then the other parts of the exam is, monitor. What's the monitor show? IV access and treatment. What should I do now? This patient looks really bad. Should I get an x-ray? That's probably a good idea. Call for an x-ray. X-rays, Medicare will pay for every single one we do a day if we have a reason. Severe hypoxemia is a good reason to get a chest x-ray. A chest x-ray can't tell me if the patient had a PE. It have to be a really big PE to see it on chest x-ray, and you have to have very good eyes to see that. But it could tell me if the pleural effusion is getting worse. It will tell me if the patient has a pneumothorax. It'll tell me if the pneumothorax is getting better or worse. It can rule out a lot of different things, so it's very helpful to get that chest x-ray. An ABG you probably have to have an order because there's an invasive procedure that actually is very painful. You stick that artery, it hurts. So an ABG. There are ABGs on your examination. Now today is not the day for me to teach you ABGs. So if you do not know ABGs, you never understood it, you need to get a little sidebar and take a little review of ABGs. I'm just going to give you some examples on how you're supposed to think about the ABG. But if this is your weakness, your true weakness, you need to study that. There might only be 2 or 3 questions, so you're still going to pass the test if you miss all of the ABGs. So don't get yourself in a wad about just ABGs, all right? But it's something that you should know because you're the patient advocate, you're taking care of the patient. So let's look at these ABGs. The first one is a pH of 7.55. Now when I go through this, I want you to be thinking, is that high, low, or normal for an arterial pH? High, low, or normal? It's high. The normal pH of arterial blood is 7.35 to 7.45. Right, so it's high. It's alkalotic. CO2, 28, high, low, or normal? You're right, it's low. A normal CO2 is 35 to 45, so it's low. Oxygen, 88, high, low, or normal? This is a hard one. It's normal because in all the books it says a PaO2. This is not an O2 saturation. This is a partial pressure of inspired air. PaO2 is 80 to 100. But I'm glad you said it was low. Remember in the very beginning when we were talking about the essentials, the 2 things that you and I do for a living, taking care of very sick patients, is improve oxygen delivery, decrease demand. So maybe the doctor sometimes says to you, well, they always have a PaO2 of around 70, so don't worry about it. 88 is very good. Well, that's true. Maybe they really walk around town with a PaO2 of 75, but right now they're in the hospital because they're sick. And my job is to make their oxygenation better. I need to enhance it, righty? So 88 to me is a little low, but it's normal. Bicarb, the normal bicarb, 24, is that high, low, or normal? It's normal. Normal bicarb is 22 to 26. That's your metabolic pathway. So here is my interpretation of that ABG. I have uncompensated respiratory alkalosis. You agree? I say it's uncompensated because the pH is not normal. They're trying to compensate, but they're not able to. That pH is very high, righty? And it's alkalotic, and it's respiratory because the bicarb is normal, but the CO2 is not. So now that's an easy part. What they might ask you on the exam is, what are you going to do for this patient? And one of the answers is not call the doctor. So I want you to look at that ABG and tell me, is that patient breathing fast or slow? Good, they're breathing fast. Their CO2 is low, which means they're hyperventilating, blowing off all their CO2. And if you remember the essentials, why do you breathe fast? Now before you answer, don't answer it. Why do you breathe fast? If you say pain, temperature, anxiety, hypovolemia, hypervolemia, slap yourself. Because there's only two physiologic reasons why you breathe fast. One is tissue hypoxia, and the other is metabolic acidosis. So when you look at that ABG, they do not have metabolic acidosis because the bicarb would be very low. The CO2 is low. They're breathing fast and their oxygen is low. So I would give this patient nasal cannula oxygen. Improve their oxygenation, their respiratory rate would go down, their CO2 would get better, and their pH would be normal. So the answer there is give that patient some oxygen. Okay? I know that's a little convoluted, but that's the correct answer. Let's go to the next one. 721, high, low, or normal. A very low, exactly. It's very low, so I'm very worried about this patient because this is very acidotic. Below 7.2 is almost incompatible with cellular activity in the body, so it's very bad. You look at the CO2, and right away you know this is not respiratory acidosis. If it was respiratory acidosis, the CO2 would be high. Remember, normal is 35 to 45, and this is low. So it's not respiratory. Oxygen is fine, but look at the bicarb. Bicarb is very low. This is uncompensated metabolic acidosis. And the reason the CO2 is low is because they're trying their best to compromise, to get their pH back to normal, but they can't do it because they're so acidotic. Right? So one is a respiratory alkalosis, the other one is a metabolic acidosis. All right. End-tidal CO2 monitoring, capnography, is a godsend to us. I don't know how you use it or if you use it. We have nasal cannulas with a little receptacle at the bottom there that catches CO2. And it's not as accurate, of course, as getting an ABG, but you can trend it very closely. When people breathe normal, in and out through their nose like that, you're going to catch all the CO2, and it's pretty good, and you'll get a good trend. When they start getting into trouble and they start breathing through their mouth, what's going to happen is your end-tidal CO2 is going to drop, and that should call you to the bedside because an alarm is going to go off and you say, why are you breathing through your mouth and why are you breathing so fast? So it's a very nice measurement tool for us. Now we'll get into that. That's mainly our physiology, and we'll get into now a little bit of pulmonary pathophysiology. Primary pulmonary hypertension is actually pretty rare. We don't see it very often. We see more secondary pulmonary hypertension. Primary pulmonary hypertension occurs mainly in younger women, and it could be secondary to a number of different things. But usually this is your friend who's 25 years old that tells you she was walking up a flight of stairs yesterday and she had to stop halfway because she was short of breath. A 25-year-old should be able to skip up the stairs backwards and not be short of breath at all. So she's short of breath. And then she tells you in the afternoon her ankles are swollen, and that makes you think of right-sided heart failure and pulmonary hypertension. Right? Now the actual definition, you need to underline that and memorize that. The actual definition of primary pulmonary hypertension is a mean pulmonary artery pressure, PAP, pulmonary artery pressure, greater than 25 millimeters at rest or up to 30 or above 30 millimeters of mercury during exercise. Those are very high pulmonary pressures, pulmonary hypertension. It can be caused by any type of vasculitis that could occur in the lung, Goodpasture syndrome, Raynaud's. Appetite suppressants. Now you have to remember that ephedrine is illegal. You cannot buy ephedrine. So the appetite suppressants used to have ephedrine in them. Now they have ephedrine-like drugs in them, and they can cause the person who's taking them to have sometimes irreversible pulmonary hypertension. So they're really not very good drugs to take. Cocaine, HIV infection can cause pulmonary hypertension. So what do we do for that? Well, what are some of the symptoms? Dizziness, shortness of breath, leg swelling. What do? We take them to the cath lab and off of oxygen and do a right-sided heart cath. So we're measuring right CVP pressures, right ventricular pressures, and pulmonary artery pressures. We can do that by passing a catheter into the pulmonary artery. then we see that they're very high, and then we give the patient 2 liters nasal cannula. Oxygen, when you give people oxygen, it is one of the best and the primary drugs that we use to treat pulmonary hypertension. I do a lot of medical missions, and I've gone to the Plano Alto, which is 20,000 feet. Now, I'm from Gainesville, Florida, and Gainesville, Florida is like -1 foot. It's in the swamp. So I went from -1 foot to 20,000 feet. Let me tell you how short of breath I was. There is no oxygen at 20,000 feet. The books tell you that humans can't live at 20,000 feet, but the Inca Indians, nobody told them. They've been living there for 7,000 years or longer, and they've adapted to that altitude. Me, when I go up there, what my pulmonary vessels all do when you become that hypoxic is constrict. So your pulmonary pressures get very high. And then you could go into high altitude sickness, flash pulmonary edema. So what we treat people with is oxygen. So in these patients who have primary pulmonary hypertension, we see if they are going to be an oxygen responder. Some people are, but there are some people who are not. Those who are not, then we could do calcium channel blockers, prostacyclins. There's a lot of new drugs on the market now for primary pulmonary hypertension that are inhaled drugs. Or is this patient so bad that they need a pulmonary transplant? Okay, so that's primary pulmonary hypertension. Now, Pfizer is a very smart company. Pfizer is the company, about 15 years ago, doctors were screaming that they needed a new drug, a PO pill, that would help people with primary pulmonary hypertension. And so they invented one. It was called Viagra. And during clinical trials, Viagra works just like inhaled nitric oxide to cause pulmonary vasodilatation. It's a very good drug. But what did they find out during clinical trials with humans? That, oh my goodness, it's very good for erectile dysfunction. Now, this is how smart Pfizer is. The population of people with pulmonary hypertension is very small. The population of people who have or think they have erectile dysfunction is very big. So they pulled the drug, they readmitted it to the FDA, and now it's the 3rd most frequently prescribed drug in the United States. The first most prescribed drug is Synthroid, the second is lisinopril, and the third is Viagra. All right? But I still need Viagra for my patients. So Pfizer being very, very smart, and Viagra is not paid for by insurance. It's a recreational drug, right? So Pfizer again says, okay, we'll make another drug that's just like Viagra, and we'll call it sildenafil, but it is only for pulmonary hypertension, and insurance will pay for it. So aren't they smart? So you have Viagra and sildenafil. So in people who have secondary pulmonary hypertension from something else, like obstructive sleep apnea, one pulmonary embolus can give you significant pulmonary hypertension. Heart failure. Heart failure is a leading cause of pulmonary hypertension, secondary, or valve disease in the heart gives a patient pulmonary hypertension. Now, what do we treat these people with? With really resistant pulmonary hypertension, oxygen, those inhaled drugs, and sildenafil. Right? So we see a lot of secondary pulmonary hypertension. This is the way we look at lung abnormalities. We're still doing more physiology. Most lung abnormalities are described as obstructive or restrictive. Now, all of you know obstructive disease because it's the most common thing we see in America is COPD, chronic bronchitis, asthma, and emphysema. And now remember, these are all diseases, but people can get emphysema and not smoke. Most people always think, well, you brought this on yourself, you smoked cigarettes your whole life, you have emphysema, I'm sorry for you. But many people can develop emphysema from alpha-trypsil-1 deficiency, and now they develop emphysema. It's usually younger women, and they have terrible emphysema, and they've never smoked. The same thing with asthma. Many people who have asthma, they've never smoked. Righty? So these are all airway diseases where people can get air in, but they can't get air out. Restrictive disease, now this is a lung problem that they can't get air in. Alrighty. Most commonly, it's because there's fluid in the lung or the lung is collapsed. So atelectasis, pneumonia, that's pus in the lung, pneumothorax, collapsed lung, pulmonary edema, fluid in the lung, pulmonary fibrosis, the development of fibrin in the interstitial space, which makes the lung very stiff, very difficult to get air in. What drug do we give people every day? Very common cardiac drug that can cause pulmonary fibrosis, and that's amiodarone. I'm sure you use that a lot. ARDS, again, because the lung is full of fluid. Obesity, we should take on the side. If patients have morbid obesity, these are patients 400, 500, 600 pounds, there's a lot of fat on their chest, a lot of subcutaneous tissue. And when they lay down, that fat now compresses their lungs so they can't get air in, and that's a restrictive disease. Restrictive. So let's talk about this a little bit more. Asthma. Asthma is a common long-term inflammatory disease of the airways, and the characteristic is airflow obstruction. They get air in, but they can't get it out, and bronchospasm, and with some fluid secretions. Wheezing, chest tightness, shortness of breath. It can be genetic and can be environmental. People develop environmental allergens, very common now. Classified according to what we look at, and we classify the severity of asthma by FEV1, forced expiratory volume in 1 minute. How much air can somebody get out in 1 minute? You'll hear respiratory do, I want you to blow your air out as fast as you can. Ready, go. Blow, 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 blow. And see how much they can get out in 1 second. We do this a lot in the emergency room too. So the treatment, lifestyle modifications, please don't smoke. If you smoke, just slap yourself. It's the silliest thing ever. Medications like beta-2 agonist. Beta-2 agonist is albuterol, fast-acting bronchodilator. Anticholinergic, that is a slow-acting bronchodilator, and it really acts to prevent bronchospasm. We put those two drugs together, you get Combivent, and epinephrine. Right? So COPD, asthma. Chronic bronchitis, there's a definite definition, and this is most commonly caused by cigarette smoking, marijuana smoking, vaping. All right. Chronic inflammation of the airways with cough, mucus production. The typical story is a patient wakes up in the morning, coughs, brings up sputum. They could be a little bit of shorter breath. They could have some wheezing, and that this every morning cough lasts for more than 3 months of the year. Chronic bronchitis. Most common respiratory disorder ever, usually caused by smoking, and the treatment again is bronchodilators, maybe some anti-inflammatories, and stop smoking. Stop smoking, or living in a smoke-filled environment. So if your partner smokes and your house is always filled with smoke, that's secondary inhalation. Right? Emphysema, again, this is one of the most common things we see, chronic inflamed disease of the alveolar sac. Now it's not just the airway, it's the alveolar sac gets thickened and stiff. Both emphysema and chronic bronchitis can have both, and smoking is the biggest problem. So the treatment then, bronchodilators, combined bronchodilators, steroid treatment, inhaled steroid treatment is very common additive. Combination medications like PDE4 and inhibitors, and some new drugs. All you need to know for the test is bronchodilation and steroids. It's usually inhaled steroids. Well, when they come in the hospital and they're really sick, maybe they can't get the inhaled steroids. Now we have to change to PO or IV steroids. Remember, anytime you start the patient on IV or PO steroids, hypertension, euphoria, shaking, and they hold on to salt and water, their blood sugar. Alrighty. So this is just a sample, an example. Here you have the normal alveoli on the left and an alveoli with emphysema. You can see that many of the septums have really just disintegrated, and now instead of 70 alveolar sacs, you might only have 30, and the walls are very thick and stiff, so they don't move very well. Thick and stiff, higher pressure. COPD exacerbation. I'm sure that you have lots of patients that are doing that. We're taping now in the winter, and I know at my hospital we have an abundance of people being admitted with COPD exacerbation, the flu, and pneumonia. Please remind your patients if they have any lung disease, they need the pneumococcal injections and they need their flu vaccine. And all of us need our flu vaccines. So the key here, this patient now comes in and they're very hypoxemic, oxygen delivery, bronchodilators, steroids. Now, if they have the flu, remember we're not going to give antibiotics, maybe give Tamiflu, but the flu is done by a virus, so be careful. Antibiotics for bacterial infection only, and care, nursing care. Well, you know, I wouldn't get somebody who is in terrible shape that's on 2 liters nasal cannula, they're satin only 88%, they're short of breath at rest. I wouldn't make them get up and walk to the bathroom. They're not going to, they have such an oxygen deficit, they won't be able to do that. So very good nursing care, get the patient up, use the intensive spirometer, do all their normal respiratory treatments and all the drugs that they take at home. Very good. So acute respiratory failure, that's probably the number one admission that you get during the winter and fall. This is actually a definition of a PaO2 type 1 respiratory failure is hypoxemia, PaO2 less than 50. Type 2 is hypercapnia, a CO2 greater than 50. It's not a great definition, but that's what it is. But you already know everything there is to know about hypoxemia. The number one cause is VQ mismatch. And what we try to do, nurses at the bedside, is recruit that lung open. Incentive spirometry, get them out of bed in the chair, bronchodilators, good pulmonary care. We shouldn't say pulmonary toilet anymore. Pulmonary care, bronchial care. Now, here's where we fall apart. We shouldn't let this patient de-recruit. So what happens is, usually during the day, we're all after this patient, you know, using incentive spirometer, sit up in the chair, walk. But at night, you know, you got to let the patient sleep. Don't interrupt the patient. Well, what happens at night when they sleep all night is they de-recruit. And we have to start all over again in the morning. So they are going to have to get up at least once during the night and use the incentive spirometer, cough and deep breathe, and move around. Otherwise, they de-recruit. The assessment of someone who is hypoxemic, well, number one, you know, remember tachycardia, the number one reason people have tachycardia is because of hypoxemia. So tachycardia and dysrhythmias, PVCs. PVCs occur, your patient's heart gets irritable and has PVCs if it's ischemic, hypoxic, acidotic, or electrolyte disturbance. So that's what I'm thinking when I start seeing those PVCs. They're tachypnic, they're going to start breathing fast, they start telling you they're short of breath, maybe restlessness, confusion, that jittery, agitated state, accessory muscles. And if we wait for cyanosis, we need a new job. If we wait for people to turn blue, we haven't been doing our job, we haven't been assessing them at the earlier phases, righty? Now, acute respiratory failure with hypercapnia is a problem of a decrease in minute alveolar ventilation. Please remember there are no equations on the test, so don't write this down, just listen. Minute alveolar ventilation is your tidal volume, you know, when you're normally breathing. In a normal man who weighs 75 kilos, a normal tidal volume is about 500 ml. So that's all the air that he's inhaling. But not all that air gets alveolar space. You have dead space, you know, this upper tracheal bronchial tree where there's no diffusion of gas. So we have to minus that 500 minus the dead space. In that size of man, it's 150 cc. So his effective tidal volume is 350 times the frequency. He's breathing 12 times a minute. So his tidal volume is about 4 liters. That's a normal tidal volume, righty? All I want you to remember is that for us, you and I are not going to measure dead space. We measure tidal volume, how much air they're taking each breath, and how many times a minute they're breathing. Really, what we really look at is, are they really expanding their chest? Are their tidal volumes good? We don't measure it, but their tidal volume's good. And what's their real respiratory rate? They're not 20, their real respiratory rate. So hypercapnic failure can be caused by CNS depression. Patient had too many narcotics during the night or during the day. They just came out of anesthesia and they weren't totally reversed, too much anesthesia. Things that, a stroke, things that would decrease the CNS, this central nervous system. Neuromuscular disorders like Guillain-Barré, myasthenia gravis, and we already talked about restrictive and obstructive disease. And then increased dead space. Increased dead space means there's a lot of air with no blood flow. So shunting and a big pulmonary embolus. Righty? Increased CO2 production means, I don't know if you've ever done an ABG after someone's had a grand mal seizure, but their CO2 is very elevated because when you use that much muscle force and your muscles are contracting so hard and so fast, it makes your muscles make CO2. Right. Now, what do we see in somebody who has CO2, increasing CO2? Well, they might be tachycardic and might have dysrhythmias. As the CO2 goes up, the pH goes down, they get acidotic, they have PVCs. But this is the most important thing I want you to remember. As you lose oxygen, your respiratory rate goes up. As you're getting hypercapnic, your respiratory rate goes down. You get sleepy and lethargic, and you start breathing slower and slower. It makes your CO2 worse and worse. So when somebody tells me, well, the patient slowly got lethargic, they were sleepy, I could wake them up, now I can't wake them up, now I really have to really shake them to wake them up. I want to get an ABG because I think the CO2 is elevated. Irritable maybe, hypotension, and high CO2s with acidosis. Right? So acute respiratory failure, acute assessment is what's their mental status? Somnolent, agitated, two different things, oxygen and CO2, increased work of breathing, nasal flaring, tachypnea, dysynchronous breathing, the chest and the abdomen are moving in different directions. Cyanosis, oh, we're not waiting for that, but signs of stress, hypertension, hypotension, tachycardia, sweaty, nurse, I don't feel good, nurse, get me out of bed in the chair, nurse, get me up, those patients that you just can't make comfortable. So the management now the management of acute respiratory failure is give them oxygen because they're hypoxemic, and somebody has to make up their mind if this patient is going to be intubated or not. Maybe they're a DNI, maybe they're a DNR, maybe we, haven't talked to the family yet. Sometimes at night we admit patients who don't have anyone to talk to, and they're not able to tell us, communicate their advanced directives. So sometimes there's a little lag between somebody writing do not intubate or go ahead and intubate. But in the meantime, we can do some pharmacological adjuncts. We can give a beta-2 agonist. Remember, that's albuterol. You don't have to wait for the patient to wheeze to get albuterol. If your patient is hypoxemic, you give them albuterol. If the bronchus is normal and they're still hypoxic and you give albuterol, that bronchus will dilate. You'll get more airflow. You will increase their oxygenation. Anticholinergic agents like Atrovent, they're very slow acting, and we never use those in emergency. The patient should have their Atrovent twice a day to prevent bronchospasm. And steroids is the mainstay treatment for anybody with any type of COPD, and maybe antibiotics if they have pneumonia. Righty? So here's how we give oxygen. It's just a normal little slide. At the bottom, non-invasive positive pressure ventilation. Very few questions on CPAP and BiPAP. Nobody uses those things in a standard way. So it's very hard to ask questions in the whole country. Every nurse has to answer the question the same way. And not everybody uses CPAP or BiPAP like everyone else. Right? So what are the indications for intubation? How do I know when I walk in the patient's room if they need to be intubated or not? Well, according to AACN, now that's who's writing your test, do they have acute ventilatory failure with acidosis? That means is their CO2 up and their pH down? Are they hypoxemic despite adequate O2 therapy? Your patient you just walked in has a SAT of 88% and they're on 60% aerosol face mask. That's hypoxemia with VQ mismatch with high oxygen delivery, CO2 retention, and the easiest one is you walk in, the patient not breathing, they need to be intubated, right? Apnea. So those are the main reasons according to AACN. Now, what's beneficial about intubating someone? Well, remember our whole premise: enhance oxygen delivery, decrease demand. When somebody is breathing 40 times a minute, their demand for oxygen is high. And where's all their energy going? To their diaphragm. Those people can't even say a sentence to you without having, every other word take a breath, because they're so short of breath. So the first thing when we intubate the patient, what will happen is you decrease systemic and myocardial oxygen consumption. MbO2 is myocardial oxygen consumption. So if I'm decreasing, with a ventilator, I'm improving delivery, decreasing demand. It's a perfect system. Maybe I can sedate the patient, and usually with intubation, good intubation, I have a secure airway. Right? Types of ventilators, there are going to be some questions on ventilation. There's only one type of ventilator we use today, and that's positive pressure ventilator. An example of a negative pressure ventilator would be an iron lung. And I don't think too many people are using that lately. So the most important goals when you put somebody on a ventilator is it reduces their work of breathing. You can get the patient comfortable. You have synchrony with the ventilator and the patient, not the patient and the ventilator. We make the ventilator do what the patient requires. And then we have airway protection. So this is how we do lung protective ventilation today. This is a very important slide. Today, the way we protect the lung, because being on a ventilator is not good for you. It actually causes lung injury. There's a thing called ventilator-induced lung injury, VILI. What we do to prevent that injury is to protect the lung, low tidal volume, lowest tidal volume that we can for that patient according to their ideal body weight, not their actual ideal body weight. And because the tidal volume is so low, the way we recruit the lung open is with PEEP, righty? And then we have to look at the right heart. Because we're increasing the pressure of the lung, you have to look at the right heart, make sure it's contracting well and it's filled well. We usually do that with ultrasound. There's lots of other ways we can do that. But we have to do all three. So for your test, righty, they ask you a question, your patient's on a vent, and you're not oxygenating, the patient is not oxygenating well. Your strategy is to go up on the PEEP. We don't like to go up on the FiO2 because that can cause oxygen toxicity in the adult. So we don't like that. So we're going to go up on the PEEP, and that always helps with oxygenation. That's the answer on the test. The next question on the test might be, what do you do if the patient's CO2 is going up? So the answer on the test is to increase the frequency of respiratory rate. So they were breathing at 8 times a minute, go up to 12 times a minute, go up to 14 times a minute. Is that what we always do? No, sometimes we do different things, but that's the answer on your test. Go up on the rate of ventilation. Right? So if your patient's hypoxic, go up on the PEEP. If they're hypercapnic, go up on the rate of ventilation. Those are the answers for your test. Now, we just intubated your patient. Your patient got acutely ill in the middle of the night. We just intubated, right? We always put the FiO2 on the ventilator at 100%. But then we quickly wean that 100%, once we get the patient more situated, and wean it and keep the sats above 94%. Remember, we don't give oxygen unless the sats are less than 94%. So we quickly wean that FiO2 maybe to 40%, 30%. Right? A tidal volume is 5 to 10 milliliters per kilogram of ideal body weight. So it's easy. Your patient weighs 70 kilos. You're going to put him on a tidal volume 70 times 5. That's his ideal body weight. Times 5 is 350. 350 tidal volume. Righty? The respiratory rate depends on his CO2. If his CO2 is really high, you're going to have to go up on the rate to wash that CO2 out. And then we add PEEP. This is just the basic ventilator. Basic. Righty? Then you're going to take the patient into the ICU. Assessment of this patient, the most common thing we see is tachycardia, maybe some PVCs, maybe a new onset of atrial fibrillation with going on the ventilator because the pulmonary pressures are high. But you're going to do all your vital signs. Make sure you try to check their neuro status before we intubate and right after. Usually after intubation, it's hard to because we've sedated the patient, maybe even paralyzed the patient while we were intubating. So here are the complications. The most common complication with immediate intubation is low cardiac output. The patient's blood pressure drops. Why? Well, you and I remember breathe with negative inspiratory pressure. When I take a deep breath, the pressure inside my chest is negative. Now I put a tube down your trachea and I'm giving you positive pressure. It increases the pressure in here, so it's always positive, and that is going to make you have decreased venous return. And if you have decreased blood coming back to the heart, you're going to have decreased blood coming out of the heart, you have decreased blood pressure. And the way we usually treat that post-intubation is with volume. And then we have all these other complications. The worst complication for me, being a practitioner, is once we put you on the vent, now I can't get you off. It's a difficulty weaning or inability to wean. So that's a bad complication. Alrighty? Now, gradual withdrawal, we look at certain numbers, there's resolution, the patient's chest x-ray gets better, they're awake, they have a normal blood pressure, they have a normal respiratory rate, all their things are normal. We extubate the patient. With extubation or decannulation, you have patients who have trachs. With decannulation, you worry about hoarseness and you worry about difficulty swallowing. So they may need a swallow study. And they may have some subglottal edema, and we might use steroids for that. We might use racemic epi for that. Right? So hoarseness, stridor. So summary then, how do we take care of patients with acute respiratory failure? Well, if they have pneumonia, we treat the pneumonia. Fluid, antibiotics. If it's asthma, exacerbation, we treat it with steroids and their normal asthma medications. So we treat the cause, whatever the cause is, positioning the patient, sitting upright, righty, hydration. Even patients who have pneumonia, if they get too dehydrated, the secretions get so thick and dried out that they can't cough them out. So we have to be careful of that. Bronchial hygiene, that's pulmonary toilet. Get the patient up, incentive spirometer, cough, brush their teeth, keep their mouth nice and clean. They may need bronchoscopies if they have a lot of mucus plugs. They may need intubation. We try our best not to intubate, and the reason is once we get you intubated, we may not be able to get you extubated. So this is the first half. Congratulations, you've done very well. This is the first half of pulmonary. A lot of information. Take a break now, get a cup of coffee, relax a little bit, and we'll do part 2. Thank you.